First talk is by Dr. Rajashree Nambiar from Little Flower Hospital, Angamali. Her talk is on anterior uveitis.
Good afternoon, all. As we begin with our session on uveitis, I shall be talking on approach to anterior uveitis. History taking and clinical examination remains the backbone of uveitis. This is followed by pattern recognition, looking for the possible etiological diagnosis, getting the relevant lab investigations done, and in non-responsive cases, we advise extensive investigations followed by treatment. Now, as we begin, let us go through the classification of anterior uveitis. It's classified based on the course as acute, recurrent, and chronic, based on the etiology as infectious and autoimmune, based on the pathology, it's granulomatous versus non-granulomatous uveitis. Now, coming to a few differences between acute and chronic uveitis. Acute is sudden onset, associated with pain, redness, photophobia. They may be self-limiting. They will have circumcorneal congestion, and IOP may be low. Whereas in chronic, it is insidious in onset, may be symptomatic. The patients could complain of floaters and decreased vision. There may be little congestion, and the IOP may be high. Now, based on the clinical stages, let us go to the few causes of uveitis. Acute single episode, the common causes are trauma and a reaction to any infection. Acute recurrent, you have your HLA-B27 related uveitis, viral, and the Posner-Schwarzman. Coming to causes of chronic recurrent uveitis, you have your viral, tubercular, sarcoid, Fuchs, GIA, and your retained intraocular foreign body. Now, differences between granulomatous and non-granulomatous uveitis. The non-granulomatous uveitis is seen in, it's usually an acute and a short duration with more of exudation, small KPs, Kopis nodules, could be seen in HLA-B27, herpes, and Fuchs. Whereas the granulomatous, it's usually chronic, insidious. There are large mutton fat KPs. You could have Bucsakas nodules and dense posterior synechiae. This is seen in TB, VKH, herpes, and sarcoidosis. Now let us go through a few cases. This was a 15-year-old boy who presented to us with a history of trauma. He had pain, redness, and decreased vision. If you see, there is significant amount of congestion with a large, with AC reaction, few KPs. So this, what we are dealing with, is a case of acute onset of non-granulomatous uveitis following trauma. There are no investigations required. This patient was started on topical steroids and cycloplegics. He came back to us after 3 days. He had gone to school and stopped all his medications. Now, you have an eye which has got a few fibrinous membranes and a little about membranes in the anterior chamber. This patient was then admitted, started on oral and topical steroids, and he's doing well. Now, this is a lady, 46-year-old female, who presented with pain, redness, and photophobia of 1 week duration. She gave us a very important history of morning stiffness and back pain. On presentation, she had significant congestion with small fine KPs and a fibrinous membrane in the pupillary area with a 3 mm hypopyon. What are we dealing with? This is a case of acute non-granulomatous anterior uveitis associated with back pain and morning stiffness. This is mostly HLA-B27 related uveitis, usually seen in 30 to 40 years of age, unilateral. Other eye may be involved later, and they are associated with hypopyon and fibrinous exudation. These are some of the other causes of HLA-B27 related uveitis, and history taking is very important so as to make the diagnosis. Now, the take home is, how do we treat this HLA-B27 uveitis? Aggressive topical steroids 1 hourly with cycloplegics to break the synechiae, and systemic corticosteroids in case your topical treatment is ineffective. As there might be a need for a longer period of high-dose steroids, immunosuppressants are added. Now, coming to your differentials in hypopyon anterior uveitis, it's immune-mediated HLA-B27 and Behçet's, infectious in endophthalmitis, and you have your masquerades. Now, what are the differences? In HLA-B27, you have a hypopyon, which usually does not move very freely, with the history, which is very important. In Behçet's, you have a shifting hypopyon. In endophthalmitis, the history is very important, looking for history of any fever. If it is post-cataract surgery, look for any infiltrate at the section. And in neoplastic, usually what we get is a white hypopyon, and these, they usually do not respond to steroids. Now, this is a 53-year-old female who presented to us with pain and redness in the right eye since 3 months with photophobia. On examination, her vision was 624. She had diffuse corneal edema with large metaphate KPs and cells with areas of patchy iris atrophy, and her intraocular pressure was 34. So here we are dealing with a case of herpetic viral anterior uveitis. Why? It's unilateral, pigmented KPs inferiorly, areas of sectoral or diffuse atrophy. You could have a dilated pupil, decreased corneal sensation, dendritic scar, and the IOP is high, usually due to viral trabeculitis. Now, these are the other viral uveitis in which we have your HSV. In HS, it's HZV. HZV, we have to ask the history of zoster dermatitis. And in CMV, as compared to the other two, the AC reaction is relatively less, and there are no posterior synechiae, and the IOP is more than 50 millimeters. Now, this is another lady who presented with a hypopyon with a little amount of blood-streaked hypopyon. So, this was a case of HSV viral uveitis. Now, what is the treatment of herpetic viral uveitis? Basically, it's oral antivirals. We have your acyclovir, 400 milligrams 5 times per day, along with your cycloplagics and topical steroids, and you have to also treat the intraocular pressures. So what are the other causes of hypertensive uveitis? Other than your viral, you have your Fuchs, Poschner-Schwarzman, etc. IOP may be low in HLA-B27 and NARD. Now, this is a 47-year-old male who had no history of any redness, but he came to us with diminution of vision. He had stellate fine KPs with a posterior subcapsular cataract. There were no posterior synechiae. He had associated vitritis. So this is a case of Fuchs heterochromic iridocyclitis. The significant features are it's usually unilateral, and the patient presents with decreased vision, usually due to cataract. There are no posterior synechiae. There could be cells in the vitreous, and usually the inflammation does not require treatment. Now, this is a 54-year-old female with pain, redness, and photophobia for over 6 months. She was on steroids, had recurrences on tapering them. Now, if you see, there are large mutton fat KPs with Musaka's nodules, significant AC reaction. We are dealing with chronic granulomatous anterior uveitis. And what are the differentials? Look for tuberculosis, sarcoid, syphilis, etc. And here, history taking is very important, followed by investigations to finish the diagnosis. Now, the investigations normally done are your CBC, your chest X-ray, Mantoux, quantiferon, HRCT for TB and sarcoid, then your syphilis and evaluation, ACTAP in case of herpes. This is a 58-year-old male who presented with history of trauma. What we see are some atypical nodules along with a blood stain. And since this was an atypical case, an HRCT was done, and he turned out to be a case of adenocarcinoma of the lungs. So finally, if diagnosed and treated on time, we can treat uveitis without long-term sequelae. And regarding the use of steroids, they usually, in patients in whom anterior uveitis is not responding to topical drugs, you can start them on oral steroids, and you have to give them use enough, soon enough, long enough to get the desired results. And you have to start at a high dose and then taper slowly. Thank you so much.
Thank you, Rajashree. Dr. Anuradha, for your comments.
Any questions from the audience? So, anterior uveitis is probably the most commonest variant of uveitis you will see. And some of the common mistakes we make is, treating all anterior uveitis the same. For example, whether you have a HLA-B27 associated uveitis or JIA associated uveitis, it's not to be treated the same way as a idiopathic anterior uveitis. Secondly, it's not like one treatment fits all patients. It's not like 6 times spread for all patients. You have to tailor it according to severity of inflammation. The other thing which we commonly see is excessive use of steroid antibiotic, which I really don't think is required in uncomplicated uveitis. If there is no epithelial defect, there's no indication for using an antibiotic here. You can use pure steroids, it doesn't do any harm. Any comments from